Hello. ¿Cuántos años tiene esta paciente? Sh- So, hello everyone. So today we have a very interesting case. ¿Cuántos años tiene? So this is a 36 years old female that came to our unit because of she needed a US, okay? Because of a cystic lesion. They sent to me because as a pseudocyst lesion, but making the clinical history of this patient never had pain, never had history of pancreatitis. So the one of the first thing that I am looking here, there is a small ascites. You see here. So a small amount of ascites that is not normal. So from one thing, one of the part, this is the liver. You can see the ascites there, and we know that she have a macrocystic lesion, right? But so today I want to show you how is the approach today. But one of the new things that we are trying to bring to the market, which is this is the cystic lesion. I want to see a little bit the rest of the pancreas of this woman. So this is the lesion. Sorry. See, it's a big lesion, huh? So this is the B mode. So what are the characteristics that I am looking in this B mode? Is there is no very clean 67 by 73, and but also I can see some walls inside. Okay, you see here this wall here, this wall here, this wall coming from here. I will come back. You see, you can see very well by B mode, but also is not clean, like you know. So due to this characteristic, probably I am looking inside of cystoadenoma, yeah, or maybe a cystoadenocarcinoma. That is the thing that we need to think right now. And this is very important. You know, the patient have ascites, and this is not normal. It's a small amount, but I believe it's not normal. So we need to evaluate this lesion. So I will use different technologies. First, I will use DFI, detective flow imaging, from the Hitachi Aloka Fujifilm technology. You can see here very well. You can see very well here. So I am adjusting. So you can see here the walls inside showing to me that these walls entirely, all the wall, you know, have you see, have microvascularization inside. So in this case, just because of the B mode characteristics and this DFI that is positive, yes. So because until now we have an objective way to say this is just positive or negative, okay. So from my side, I believe this could be a mucinous cystoadenoma or cystoadenocarcinoma, because there's a small irregular vessels that I'm looking inside, looking this technology. However, you know, we need to make more studies to see more data about this hypothesis, or this just visualization, or this characterization that I'm looking in this lesion. So now I want to show you a little bit more. Let me see. So now I want to show you a new technology before make a confocal. I want to make a confocal here. So we have to use confocal right now in cystic lesion. Showing all the meta-analysis and the studies that this is the best way to evaluate cystic lesions. So thank you to Mauna Kia to support us. Now I want to show you AI technology. Podemos prender, no, espérate. ¿Puedes poner en grande el AI? Okay, so now we have this technology that help us to evaluate the microvascularization that we are looking in the lesion. Okay, puedes ponerlo. Pum, start. No, hay que resetear. Okay, so now you can see a lot of vascularization, you see? So this is very interesting and very important. You can see here, you see the quantity of microvascularization from the wall is taking the AI, something that we cannot measure in terms from the human visualization. So for visual impression, yes, I can say yes, there is vascularization inside, but I cannot count the number of lesions. So you can see here, there is the machine is taking 218 as microvessels that were measured in a mean vascularity of 124-26 in between the 60 frames per second. So it means this is a lot of vascularization. This is a lot of vascularization. So microvascularization is the future for diagnosis, not just cystic lesion, but also other kind of disease in the liver, in the spleen. I believe that will change for sure the future of endoscopy. So, but now we need to focus a little bit on new technologies like AI. Because sometimes it's difficult. If the beam mode of this patient was clear, for example, the liquid, I will not be sure. The other day I make a live transmission, a lot of vascularization, but not like this one, 235 with a mean of 84. So comparing cystoadenoma versus cystoadenoma mucinoso versus cystoadenocarcinoma versus zero cystoadenoma, there is a difference at least. Right now, I am looking, in a small series of patients that we start to do it in our institution. So we are looking this, and we are seeing that this will help. This will be the future of new evaluation of these lesions and having a very good objective way to measure the microvascularization and not just to say there is or there is not, right? So we know that the walls, you see, have a lot of microvascularization. So the software is showing everything. Quiero volver al modo normal. Sí, no, sí. Okay, so now we are coming to the normal way, you see, and then I want to show you the glossy view. And you can see, look at this image, and you can see the microvascularization from the wall, like almost in 3D reconstruction. It's very interesting. So now you can see beam mode again. I will make another picture of this area with DFI and dual DFI. You can see here, look, very clear. Wall. You can see here, you see, very clear microvascularization. So I confirm that this lesion is not a pseudocyst for sure, and we need to obtain tissue. As you said, tissue is the issue in United States, for example. They say that. So from my opinion, this patient is have just because of AI and the microvascularization, this patient have a mucinous lesion. You see, I'm there. I will push my confocal. Okay, I will try to go a little bit more deep just to see the wall. Le pasamos el contraste. It looks I think it's different, huh? I need to evaluate a little bit better. Okay. This could be also an neuroendocrine tumor. So, big lesion, I never saw it so big, but you know, everything is possible right now. I'm a little concerned, you know, because the microvascularization is too high, and neuroendocrine tumors are also, a lot of vascularization, have a lot of vascularization. And what I look in here, at least in confocal, it looks like that. I can see like the normal appearance of mucinous cystic lesion, but well, we need to evaluate better right now. Yeah, I believe yes. This patient doesn't have pain, doesn't have any other, clinical characteristics, so probably it's not a functional one, but it's a big one. It's 6 centimeter almost. So this is a, how to say, and this was detected just because of blood. This is the wall. Yeah. So for my opinion now, probably this is an endocrine tumor. We need to. I will take a biopsy for now. Yeah, I don't see the normal characteristic of other lesions or mucinous lesion. So let's see. Let's see. I will take a biopsy now. So yeah, I believe this is a neuroendocrine tumor. Yes. Okay. So now I will stop confocal. Okay. So I remove my confocal, you can see here, and I will take a biopsy using the Murray forceps. There's some studies, well, there's one big study showing the risk of this forceps. Yes, there's a risk of mortality even, it's not a big situation, but it could happen, so we need to take care of this. So now I am passing the Murray biopsy forceps. Abre. Cierra. Abre. So you see the forceps here is open, you see? So now I'm pushing. Cierra. Now I have, you see? Take it. You need to take care because there is risk of bleeding also, huh? So you see there is some bleeding inside, just small, you see? I can see it. ¿Tienes algo? I will take another one. And I will take some liquid for evaluation, analysis. So very nice case. I want to say thank you today for joining us, and we will see you in few days for Euro US. Abre. Cierra. Cerraste. Okay. So now I take it 3 to 4 biopsies, and then I will take the liquid aspiration. So thank you so much. Once again, see you soon. Chao. Cortamos la